Good afternoon, everyone, and welcome to today's Expert Series webinar, Healthy Bones, What You Need to Know About Osteoporosis and Diabetes. I'm Donna Rice, Chief Operating Officer at Diabetes Sisters, and I am so glad that you're here with us today. So today's session is made possible through our valued partnership with the Bone Health and Osteoporosis Foundation. For 40 years, this foundation has been committed to preventing osteoporosis and raising awareness about bone health through education, advocacy, and research. This afternoon, we'll be exploring the important connection between diabetes and bone health, and I'm honored to welcome an expert to guide us through this discussion. It's my distinct pleasure to introduce our featured speaker, Dr. Karen Kemmis. Dr. Kemmis is a physical therapist, registered nurse, and an adjunct professor at SUNY Upstate University in Syracuse, New York. She is the team leader of the Diabetes Care and Education Specialist at Syracuse affiliate of the Joslin Diabetes Center. Her impressive academic background includes a doctorate and bachelor's degree in physical therapy, a master's in exercise science, and an associate degree in professional nursing. Dr. Kemmis is a board-certified geriatric clinical specialist, a certified diabetes care and education specialist, a certified exercise expert for aging adults, and she serves on the board of trustees for the Bone Health Osteoporosis Foundation and is a past president of the Association of Diabetes Care and Education Specialists. Karen is a sought-after speaker and has presented nationally and internationally on topics related to aging, diabetes, and osteoporosis. Please join me in giving a warm and heartfelt welcome to Dr. Karen Kemmis.
Thank you so much, Donna. I'll go ahead and share my slides.
Okay.
Thank you so much for that great introduction, Donna. I am so happy to be here, and I'm thrilled to have everybody joining on what I think is an incredibly important topic. As Donna mentioned, I work at the Joslin Diabetes Center. I've been a diabetes care and education specialist for 29 years. When I first took the position, I didn't know much about diabetes or osteoporosis, and over the years, I've had great exposure to both. So it's an area that's a huge passion of mine. And what I'm most happy about today is that Diabetes Sisters has brought this to you because I think a lot of people know about osteoporosis, and certainly I assume you all know a lot about diabetes, but I think the association of the two is often overlooked. So hopefully we'll get through some great information today and raise that awareness. So within this presentation, I'm going to discuss what osteoporosis is. I'll describe a lot of the different pieces that affect bone health. I'll give an overview of how osteoporosis can be screened for and diagnosed, and then a couple of tools you can use to determine your fracture risk. I will talk about the relationship to diabetes, and this isn't really a separate category within the talk. You'll see it scattered through the whole presentation and lots of different aspects of this. And then we'll talk about some positive things that you can do to help slow bone loss and prevent fractures. Just a little snippet on the medical information I share is really informational. And of course, you would work with your own healthcare provider to make your individualized care plan related to osteoporosis. I am on the board of trustees for the Bone Health and Osteoporosis Foundation, but as Donna mentioned, I have a long history of very deep involvement with the Association of Diabetes Care and Education Specialists and with diabetes in general. So let's start with the basics. What is osteoporosis? It's defined as low bone mass, deterioration of bone tissue, and a disruption of the bone architecture, which creates compromised bone strength and an increase in the risk of fracture. And that's the bottom line. To have a diagnosis of osteoporosis isn't necessarily so important. It's that risk of fracture that can be caused by having osteoporosis. So on this slide, we have these, it's a CT micrograph of pelvic bone. On the left, there's one of a healthy younger individual with strong, there's a lot of bone density showing. All the crossbars are attached. It looks like good, strong bone. And on the right, we have a piece from the iliac crest of an older individual with osteoporosis. The first thing you'll see on the right-hand side is that there's a lot less bone there. There's just less bone mass. But the other thing that is so important is I'm hoping you can see where those little crossbars have breaks in them. So not only is there not enough bone, but the bone isn't necessarily structured to help support us. So if this was the framework underneath of a bridge that you were driving over and you had the options of the framework being built out of what's shown on the left versus the right, of course, we would choose what is on the left. It's got more support to it. It's stronger. It will not fail. So osteoporosis is a really serious problem. It affects almost 54 million Americans, with 10 million actually having the diagnosis of osteoporosis, and then about 43.5 million having low bone mass. I equate this to diabetes, where osteopenia or low bone mass would be similar to having prediabetes, where testing levels are not yet at the level to be diagnosed with diabetes or osteoporosis, but it's a precursor to having osteoporosis. Of course, the important thing we're here to talk about is that people with diabetes are at increased risk of having osteoporosis and increased risk of having fracture. Similar to diabetes, where many people are not diagnosed, osteoporosis has the same situation. 70% of individuals 65 and older who have osteoporosis have never been screened, and they have no idea that they have it. And so, like diabetes, once one is given the diagnosis, we can do positive things to help manage our disease. With osteoporosis, it's the same thing. If people aren't aware that they have it, then they can't do the positive steps to help decrease risk of problems. So bones are living tissue. It's easy to think of bone as like a dead piece of chalk. It doesn't change, but that's not the case at all. Bones have two cells that do activities that help help bones remain strong. So the osteoclasts are depicted by the construction worker on the right. They remove old or damaged bone. And of critical importance is the osteoblasts, shown on the left, are the cells that help to build back bone. So through most of our growing years, we have a nice alignment between the two, and our problem comes in when there's a mismatch, especially in women during the menopause, where the osteoclasts are more active and the osteoblasts can't keep up. An easy way to remember osteoblasts and osteoclasts: osteoclasts have the C for chewers, and osteoblasts have the B for builders. So we want the osteoblasts to be very active. So it's been shown that bone remodeling occurs every 7 to 10 years. You're having a full remodel of bones. So we really can affect bone tissue with positive steps. So here is a nice graphic of how the bones change. During the first few decades of life, the osteoblasts are very active, more so than the osteoclasts, and as a result, there's a nice building up of bone. So children, teenagers, people in their 20s are building bone. By about the age of 30, we've hit our max, things plateau for a while. And then, as with many other things, as the years go on, things start to go downhill. But specifically in women, there's a decrease in bone density that's quite rapid. In the 5 to 10 years following the menopause, there can be up to a 10 or 20% bone loss. So it's really important to do any step that we can to increase the bone accrual so that our peak bone mass is as high as it can be, and to slow down the shift in that loss of bone that we're all going to see naturally over the years, but we don't want such a sharp slope. So there's a lot of risk factors for osteoporosis, some that you can change and some that you can't change. The set on the left are things that you can't change. So non-modifiable risk factors. You can't change gender. Being a female increases your risk of osteoporosis. About 80% of individuals that have osteoporosis are females. So it's important to remember that 20% are males if there are men in your life, but 80% of us in the female gender will have increased risk of osteoporosis. Genetics accounts for a huge amount of our risk for osteoporosis. If you have a parent, mother, or father that has had osteoporosis, it increases your risk greatly. Genetics probably makes up for about 60% of our risk of having osteoporosis. Age, as we grow older, we have increased risk of osteoporosis. So if everything looks the same, an 80-year-old will have much more risk of osteoporosis than the equivalent 60-year-old. Having a fracture history, and I'll talk a little bit more about that as far as what types of fractures would qualify. There's some medical conditions that can increase our risk for osteoporosis. I'll talk more about that on the next slide. And there are some medications that you can't change that you need to take for a really important reason that could contribute to osteoporosis. Now, fortunately, there are things that we can change. Having adequate calcium and vitamin D intake, being physically active, and I'll give specifics on those. Limiting alcohol consumption. If we take in too much alcohol, we would tend to not take in food to support healthy bones, and alcohol consumption can increase the risk of falls and therefore fractures. Any smoking is detrimental to the bones. Having low body weight. So we'll talk a little bit in the exercise part about as we load bones, they actually respond by becoming stronger. Having a low body weight and a lack of stress on the bones, especially during the growing years, can cause less bone density. And then there are some medications that we might be able to change. So it is useful, in general, to work with your primary care provider, a pharmacist, to go through all of your medications to see if all of them are necessary for your good health. So let's look at a few of the conditions that can cause bone loss. There is a much larger list. I have the link on this page, and it's on the tip sheet that we've created, but these are some real big ones. So taking in excessive alcohol, as I mentioned, that could decrease the healthy eating that we have and increase the risk of fractures due to a fall. Having cancer and certain cancer treatments, and this can include certainly chemotherapy, but even other therapies can cause harm to the bones. Certain treatments for cancer that affect our sex hormones are especially harmful, but there's others as well. Having Cushing's disease, where there's an increase in cortisol, can be harmful to the bones. And then, of course, this is why we're here today. Having either type 1 or type 2 diabetes can cause bone loss. I'll just do a quick little delve into that here. Individuals with type 1 diabetes, some of the thought is in the growing years, perhaps having bouts of hyperglycemia can get in the way of the bones getting their full growth. So density and mass would be decreased. People wouldn't hit necessarily that peak that we want. I think both with type 1 and type 2 diabetes, there's the increased risk of some inflammatory processes going on that can be harmful. So then how else is type 2 diabetes affected? Because oftentimes, as we know, individuals with type 2 diabetes may be more overweight than underweight. And I already said that putting stress on the bone with having sufficient body weight can help bone density. It was determined many, many years ago that individuals with type 2 diabetes with normal or even increased bone density have an increased risk of osteoporosis and fracture. So having a good bone density test alone is not enough to say that you're safe from having osteoporosis and fracture. And I'll talk more about that in a little bit. Having eating disorders, not taking in enough calories, not enough protein, not enough of the right vitamins and minerals can affect the bone density. Having hormone deficiencies, especially estrogen and men testosterone. Having liver disease can get in the way of vitamin D metabolism. Having malabsorption, we know that individuals with type 1 diabetes are at increased risk of celiac disease. As it's treated, then this would bring the risk back down. But all of these malabsorption situations mean that we're probably not getting enough of the vitamins and minerals that support good bone health. Having an organ transplant, mostly due to the the immunotherapy drugs that are needed after having an organ transplant. And then rheumatoid arthritis is an especially big risk factor because the disease process itself harms our bones, as well as many of the medications that are taken to help manage rheumatoid arthritis. I'll talk in a moment about steroids. So leading into medications that cause bone loss. This is a very small part of the incredibly large list of medications that can cause bone loss. So I'll run through them fairly quickly, but anticonvulsants, aromatase inhibitors, and androgen deprivation therapy, both to treat cancers. Blood thinners can get in the way of bone metabolism. Chemotherapy, as I mentioned with cancer a moment ago, specifically methotrexate can be harmful. Cyclosporin, lithium, which is, of course, for psychiatric disorders. Proton pump inhibitors can harm the calcium absorption from the gut. Selective serotonin receptor inhibitors, again, for some psychological issues, can be harmful. Steroids is in bold. Steroids are especially harmful to the bones. So anybody who's on steroids, no matter what their other situations are, should consider that they're increased risk of osteoporosis and fracture. Tamoxifen in the premenopausal years can be harmful to the bone. Actually, when it's taken postmenopausal, it can be helpful to the bone. And then here we have a diabetes medication. The thiazolidine diones, the specific brand names currently available are Actos and Avandia, have been shown to be harmful to the bones. Probably because of that, they're certainly not one of the common drugs used to help us with glucose control. And certainly in anybody who's at risk of osteoporosis or low bone density. And then high doses of thyroxine. And again, this is a small snippet of the list that you would see if you go on this link. So if you have those conditions, or if you do take medications for certain things, it's worth having a conversation with your provider to see if you should take some positive steps for your bone health. So what would the next step be? Screening and diagnosis. So there's several ways to screen. Screens don't give us the diagnosis. They lead us to get a test that creates the diagnosis. So what are some pieces that we should pay attention to as a heads up that there might be a problem with our bone health? Having height loss. It's not unusual to lose a 1/4 inch or maybe even 1/2 inch of height over time. But if we stand in our best erect posture, that's about all we should lose. If somebody has a sudden height loss of about 1 inch, it is highly suggestive of a fracture in a vertebrae, one of the bones of the spine. About 2/3 of vertebral fractures, or the bones of the spine, that come on without trauma are silent. So the way this would be picked up, unfortunately, is from height loss, and this isn't as perceptive as pain would be. So if you notice you or somebody around you has a quick height loss of 1 inch or so, an x-ray should be done to see if there's a fracture. Having a wrist fracture, and I'll speak more about this in a moment, but that's a fracture that people will say, oh, well, I fell, it's not a big deal. It is a big deal. It gives us an early sense of the quality of bone. Having a low impact fracture, so a fracture that occurs with little to no trauma, is a red flag for having challenges with quality or quantity of bone. Other screening can be done with a fracture risk assessment tool, and I've got 2 to show you in a moment. And then there are peripheral screenings, some like ultrasound of the heel or peripheral DEXA of the fingers. They can give you some sense about your bone density, but they can be misleading, either over or under diagnosing, if you will. So if you're at high risk of having osteoporosis, then it's worth having the gold standard bone mineral density test called a DEXA. You'll see on the bottom right of the slide, it's dual energy X-ray absorbed geometry. And that is how we diagnose osteoporosis. This should be done for women age 65 and older, men over 70, or anyone younger with a risk factor. So having diabetes is a risk factor, and insurance should be supportive of having the bone mineral density test done. In my office, I am directly across the little hall from where our DEXA machine is. And I always think when people are nervous going in, I want to say, this is the easiest test you're ever going to take. You literally, I bet some people here have already had this done with clothes on, essentially, as long as you don't have a zipper in front of your lower abdominal area. You lay on the table, you're positioned properly. The technician stays right in the room. It is incredibly low as far as radiation is concerned. It's about 1/10 radiation of a chest x-ray. It's simple, it's painless, and it's fast, and your results come up really quickly. I will say it's not a perfect test. The radiologist who reads the report needs to be aware of certain things to look for. If somebody has a lot of arthritis in their low back, that will skew the results and make the bones look thicker than they are. So there has to be a good interpretation, but this is what we have for the gold standard. And this shows you what you'd find out from the DEXA test. You get a T-score, which is a statistical measurement. Anybody remembers from some math that they had in the past. 0 on this little ruler would be equivalent to a 30-year-old female. That's when our peak bone density occurs. So I, as a much older than 30-year-old female, would be compared to a 30-year-old female. If my score is -1, less than that 30-year-old female, but only down to -1 standard deviation, or greater, then I'm considered to have normal bone. If my score is 1 to -2.5 standard deviations below that average peak bone mass, or -1 to -2.5, it would be said, then I have low bone density, also called osteopenia. If my score is -2.5 or 2.5 standard deviations below 0, then I would, or more negative, then I would be considered to have osteoporosis. So if you have a T-score of -1 to -2.5, time to take positive steps. And if it's -2.5 or more negative, probably more elaborate, including medications. But important to remember, bone density only accounts for about 30 to 50% of our fracture risk. I mentioned before how much genetics has to do with it. So interestingly, if we look at the numbers of people who get fractures from bone density issues, more occur in people with low bone mass or osteopenia than osteoporosis. And part of that is because more people are living that have osteopenia or low bone mass. But so it's important that anybody who has decreased bone density or bone strength take this really seriously. So what are the other factors? We already talked about age, gender, race. Generally, people who are Caucasian, Asian, have more of a risk of having bone health issues than individuals who are Hispanic and Black, but all women are at risk. Having a bone mineral, BMI that's, like I mentioned before, less than 20, or somebody who is slight of build, having a medical condition like diabetes is going to increase your risk. Medications that we talked about, lifestyle such as any tobacco or too much alcohol, having a fracture history and a family history. So especially if you've had a fracture and your bone density looks okay, we must look beyond that because that's not the whole story. Another piece of getting the DEXA that is available on many of the DEXA machines now is the trabecular bone score. So all the DEXA looks at is front to back, how thick the bone is, it picks up how dense the calcium deposits are. But it doesn't look at the quality of bone. So trabecular bone score does that. It looks at the quality, specifically the architecture, the microarchitecture, and talks to us about fracture risk. So the very first graphic I showed you that had all that thick bone and the cross bridges were all nice and strong and solid. We want to know when it's not like that. So what I've shown here in the graphics on the far left, it's got two different people with the exact same T-score on their DEXA. Slide to the right and you're going to see the top person has normal bone architecture shown from this TBS score, where the person below has degraded. But there still is enough bone in the whole space that the T-score is equal. Go to the right, the box on the top shows at a microscopic level what the pattern of the bone trabeculae would be. And the lighter colors are better because that shows that there's bone there microscopically. Whereas the bottom, the red box shows if somebody has broken up trabeculae. So all those cross bridges that aren't nice and solid and structurally sound. So that's going to increase the risk of a fracture. This is really important for individuals with diabetes and some of those other causes of osteoporosis. So if you get a bone density and they say it looks good, try to see if you can, before you go in, if the trabecular bone score is available and can be ordered, because this is what looks at the quality, not just the quantity of bone, and that's really important with individuals with other risk factors. So I mentioned the wrist fracture, excuse me. Let's look at low trauma fractures. So having a fracture as an adult with minimal or no trauma should be considered a red flag. Lots of people can fall from standing height, walking, running, and fall forward and get a wrist fracture. And it's easy to say, well, I fell, so no wonder I got that. Well, lots and lots and lots of people fall and don't fracture their wrists. So this is a heads up. This is a sentinel event that should make us aware that the bone quality could be challenged. Unfortunately, most people that have a low or no trauma fracture have no workup for osteoporosis. So the cast goes on, 4 to 6 weeks later, the cast comes off and we go on our merry way. About 80 to 95% of people who have high risk factors and have had a fracture get no workup, no discussion about osteoporosis, no DEXA test, no talk about medications. And then what can happen? 10, 20 years down the road comes a hip fracture. So we need to be attentive to any fracture that happens with minimal or no trauma. If you or someone you know has had a fracture from something short of a motor vehicle accident or a fall from higher than standing height, then this should be considered. Have a discussion with your healthcare provider. So now I've got two other easy to access fracture risk tools. The first one is Frax. This is out of Sheffield, England. You can go online and get it, easy to get to. It estimates your 10-year risk of a fracture. It'll give two values, the 10-year risk of a hip fracture and of a major osteoporotic fracture. It's the data that went into it is suited for individuals, men or women who are 50 or older, who have low bone density and have not taken an osteoporosis medication. It is not built to evaluate the 10-year risk for somebody who already has osteoporosis medication in their system. If you go on and take this and have not had a bone density test, it's fine. You can take it without having that value. It will still calculate. So a great way to see if you're at increased risk of having osteoporosis or a fracture. A second fracture risk tool is available at this link I have here, and that's on the tip sheet that we provided. It's the fracture risk calculator, a little bit broader age range. It's for men and women 45 years and older. And it asks more questions about some of the different pieces of health history that are not included in Frax. Specifically, you're going to see that having type 1 or type 2 diabetes is one of the questions that's asked. So probably gives a better estimate of the fracture risk in individuals with diabetes or some of those other risk factors. So I'd highly recommend you go on and do this if you have the opportunity. So what do? there are many things that we can do to positively affect our bone health. Good nutrition, and I put calcium and vitamin D. Those are the key mineral vitamins affecting bone health, but a well-balanced diet with enough protein is incredibly important to make strong bones. Being physically active, not smoking, not drinking too much. How is that defined? 1 drink per day for women, 2 drinks for men. That doesn't mean if you don't take in that much alcohol, please don't. But if one takes in more than those amounts, it's going to increase our risk of problems with bone health and increased risk of falls. And then the other really, really important thing is fall prevention. In bones that are maybe moderately healthy, if one falls, even with medications to help bones and all these other healthy lifestyles, it may not be enough to prevent from fracture. So fall prevention is incredibly important. So I'm just going to touch briefly on calcium and vitamin D. There's another presentation coming up next week that's really going to delve into healthy eating for prevention and care of osteoporosis. So I'll just start with calcium. Calcium is essential. It's the key mineral that makes up bone. The current recommended daily allowance is 1,000 to 1,300 milligrams per day. And this can be captured by about 2 to 3 servings of calcium-rich foods. Calcium should be taken, we should take in enough calcium to support those amounts. We should not take in too much calcium. So there's nice calcium calculators, and I'm sure you'll hear about these next week. The best thing to do is determine from foods, food and beverages, how much calcium you take in during the day, and only supplement if you're not meeting those healthy goals. And these might be a little bit different if you talk to your healthcare provider, individualizing your care, but it's not better to take more calcium. It can cause other problems. So as you can see on the left, the top thing listed is dairy. Dairy is a great way to get enough calcium. 2 to 3 servings a day of yogurt, milk, cheese, other types of dairy products should be sufficient. But there's reasons that some people may not choose to or be able to take in dairy. So fortunately, we've got other options, proteins, vegetables, and some other foods. So now let's take a step back and think about diabetes. As you look through this list, you're going to say foods that you would say, I know that this is not going to work to support my glucose management. I'm going to call out pizza. So fortunately, there's a lot of options. Looking at the proteins, we know how important protein is in general health and doesn't affect blood glucoses very much. So this is a great way for somebody to kind of pull in all the important parts of your health and get some good calcium in there. And then vitamin D is essential. If there is not sufficient vitamin D in the body, we cannot retain our calcium. So through the intestine, we have to have vitamin D to allow calcium to be absorbed into our system. Vitamin D is the sunshine vitamin, but that is not a reliable source of vitamin D. First of all, so I live in upstate New York. We probably have 8 months of the year that I'm not going to have much skin exposure. It's too cold. It's pretty cloudy up here. So my skin will not have good sun exposure. And our skin is where vitamin D is metabolized to become the usable source. The other thing is for cancer prevention, for skin cancer, we want to cover our skin. We want to put on suntan protection. So we're going to block out those beneficial rays. We should be getting about 15 to 50 micrograms in a day, which is about 6,000 to 2,000 international units. When you go to the store, that's how you're going to tend to see them packaged. But because it's so hard to get enough vitamin D from the sun, maybe we go to diet. Not a lot of great sources of vitamin D in the foods that we would commonly eat. You might be different, but certainly dairy products fortified with D are an excellent source. There are fortified cereals and juices. Again, I go back to glucose management. Those might not be your best options because they will elevate your glucose. And if we're eating cereal, we're probably having milk, so even more carbohydrate. Fatty fish, salmon and sardines, so that's a possibility. And then egg yolks, there's some potential concern there. We don't want to take in all of our vitamin D from egg yolks. But fortunately, supplements are not expensive and they're super easy to take. So I'd suggest go to the pharmacy. If you have any concerns about your vitamin D levels, I take very few vitamins and supplements, but I do take 1,000 international units of vitamin D every day. So easy to take in. And then my area of expertise and interest, being active. Bones like to be loaded. If we load bones, they respond by being stronger. And if we unload bones, they respond by being less strong. But we need enough to surprise the bones. So let's say you go for a 1-mile walk at a 30-minute per mile pace every day. The bones will kind of at best stay where they are. They won't improve because they're accustomed to doing that. One thing to think about is activities that strengthen muscles also strengthen the bone because muscles run parallel to the bones. So in pre and postmenopausal females, we benefit through specific types of exercise that will put stress on the bone. And these are aerobic style exercises with impact and resistance exercises. So I'll talk a little bit more about this in my workshop that I'll do in a couple of days. But basically, there should be enough impact that it's outside of what your bones are accustomed through your daily life. So we've got some jumping and some stepping and some dancing, all that are going to produce more impact than regular moving about during your day. And then resistance exercises, and these should be hard enough that they cause some strain. And I've put some specifics on the tip sheet. So not something that a little weight that you could lift 30, 40 times, that's not a surprise to the muscles or the bones. It has to be something that you're going to fatigue by about 8 to 10 repetitions. So this little graphic shows how much load is placed on the bone with certain activities. And these are estimates, but let's say you go for a brisk walk. That's equivalent to about 1 to 2 times your body weight as far as impact into the bones. Now let's keep in mind too, a brisk walk does not affect anything probably from the waist up. The lower extremities and the low back are getting some impact. So if we're doing weight bearing, we have to remember upper extremities as well. Let's go up to a run jog. This is estimated to put about 3 times your body weight through your bones, so that can be quite helpful. But what's been shown to be most helpful is about 4 times your body weight load through the bones. So jumping and strength training. But a lot of things can do that. Even like a nice jumpy dance can help us as far as that's concerned. Some things are not helpful for the bones. People who swim are not putting any load through their bones. So, and even bicycling, there's no real load because there's no weight bearing. So if those are activities you enjoy and participate in, that's great. They have so many other benefits, but you'd want to embellish that with something that's specific to bone health, such as resistance training or some impact exercise. Too much load can be a problem though, and specifically our area of concern is in the spine. So the graphic on the left shows somebody who would be looking to the left of the screen, their spine. The little black parts out the back are where you'd feel the bones on the back of your spine. There should be a soft inward curve in the neck, a soft outward curve in the thoracic area where the ribs are, a soft inward curve in the low back, the lumbar region, and then the sacrum or the tailbone comes out. The most vulnerable area for fracture is in the mid to lower thoracic area. You can see the circle in the graphic on the right. If that person rounds forward through that area, they put too much pressure on the front of that vertebral body, and that naturally on all of us is the weakest part of the vertebral body, and you can get a compression fracture. I mentioned before, about 1/3 of these are picked up by the individual and 2/3 are not. So it's really important to move safely. And if there is any pain or even any height loss, to get things checked out. So keeping your spine in the best position protects the bones, protects the discs. That's how we should move. So hinging at the hips, keeping the spine in that natural posture is really important for safety. So improving posture might be necessary to be able to do that. You can work with a physical or occupational therapist to work on good posture exercises. I put 2 links here for some programs that Bone Health and Osteoporosis Foundation offer to really focus on posture. Posture work should be individualized. You may have certain postural faults that need to be worked on that are different than somebody else's, but there are some common threads. I do like the exercise shown on the bottom right here. And as you're sitting there, maybe try this just with your arms up at your sides and then squeeze your shoulder blades together. And you can hold that for about 3 seconds and release and do about 10 in a row. You might feel a little stretching in the front and you'll feel some work in the upper back. And this is really useful to help bring us up out of a posture that we tend to be in often during our days, which is kind of forward and rounded over. And then of critical importance is preventing falls. Most osteoporosis related fractures are the direct result of a fall. This is true for wrist fractures, most shoulder fractures, about 50% of the vertebral fractures. Some are from movement, like I said, but others are from a fall. Pelvic fractures, ribs, and then there's other. And of critical importance is over 90% of hip fractures in adults over 65 are caused from falls, most typically onto the side, like this woman shown in the picture. So we want to prevent that at all costs. You know, people with diabetes may have an increased risk of falls, especially if there's nerve damage affecting the foot ankle area with neuropathy, visual changes. Vision is very important in fall prevention. So if you have balance issues, increased risk of falls, it's something to be proactive and work on. There's lots of things that we can do. This is a small list. The CDC has some really nice home and personal checklists to prevent falls. Stop multitasking. I will say the one time I tend to fall off to the side into the clothes racks in the closet is when I'm, one leg up in the air, putting my pants on, looking on the shelf for what earrings I'm going to wear that day. Focus on what we're doing to avoid falls. Removing trip hazards. And this can be including being aware of little animals around the house, but certainly rugs that are not fastened down well, cords going across walkways, getting your eyes checked. Vision is incredibly important in having good balance. Keeping a night light on. If we get up to go to the bathroom during the night, I suspect you're all the same as me. It's not the best time for your balance, so it's easy to get off kilter. So to be able to have your vision helping out is really important. Getting medications checked. We talk about polypharmacy, and with fall risk, taking 4 or more medications of any kind at a time increases your risk of falls. And then certainly if there's any that can create low blood sugar, lightheaded, dizziness, grogginess would be worse. So really trying to look at all medications, what needs to be taken and what might be able to go away. And then doing balance exercises. So what helps as far as balance exercises, doing some that are in a still position, static, and some that are moving. The top left-hand picture shows a static single leg stance. The picture next to it on the right shows Tai Chi. Tai Chi is an exceptional way to help balance. A community program off of a video doing Tai Chi 2 or 3 times a week is a great idea. They must be challenging activities and they should be done in standing. Sitting balance exercises really only help sitting balance. And then some agility work like shown on with the person on the right. So with balance exercises, if you do feel like you have balance challenges, I would get a referral to physical or occupational therapy and get started in the right direction. They should be challenging, but you always want to be safe. And then the final piece is medications. So sometimes medications are really important for you. If you're at risk, talk to your provider about different options and determine what's best. There's several classes of medications that are available. They work in different ways. Some help to slow the bone loss. Some help to build bone. It will depend on what your situation is. So you'll work with your healthcare provider to determine what's best. You probably hear about some negative side effects that can occur with osteoporosis medications. When looking at the risk benefit, the benefits of avoiding fracture is so important if you're at risk. Most of the medications decrease risk of fracture by at least 50%. So that's incredibly important, especially if we think about spine or hip fractures. So determine with your provider which one is important. The risks are actually very minimal, really infrequent. So keeping things into perspective for what's important for you. So wrapping things up, it's important to know your T-score, keep a copy of your bone density tests, but at the same time, appreciate that that's one piece of it. And when somebody has diabetes or any of those other risk factors, we want to elevate our concern about the risk of fractures. Know your risk, get screened, think about all the different aspects of your health and your life to determine what's important, get diagnosed, practice good nutrition, and this aligns with what we'd ask for anybody, including individuals with diabetes. Food is the best way to get your calcium, vitamin D, protein in, supplement if needed, but we do want to try to lean towards food. And then doing weight bearing, resistance, and balance exercises every day, especially if these are areas of your concern. And with that, I thank you and turn it over for questions.
Thanks, Karen. You could go ahead and maybe take your slides down so that we could see you.
Do that.
That was such a thoughtful and practical presentation. I learned so much. So thank you so much. And for everyone out there, Karen has put together a really nice tip sheet that has some of those references on there. So, and it is available for download in our resource center. So if anybody has a question, go ahead and put it in the Q&A. And Karen will be doing an interactive workshop on May 22nd at 12 noon that she's going to focus really heavily on exercise. And then Janice McLeod, a registered dietitian who's done some great presentation and worked with us before, will be doing actually one on May 29th with a focus on nutrition. And as Karen said, you know, the two cornerstones are really the nutrition and the exercise and building bones. So for those of you who are interested or may have osteoporosis, please join us. It's your time to ask questions and really learn some practical tools and tips to help support bone health. So let's transition to some questions and answers. And I think we have a few minutes, so I want to go ahead. And first question, you mentioned the T-score, right, from the bone dexagram or whatever it is. Now, what about the trabecular bone score? Is that different? That's the question.
It is. It's a totally different bone score, and the interpretation would be given. So it's not going to be with those T-score values like I talked about. They would have a totally different interpretation, and there's different scoring, and the interpretation would have what your risk is based on that. So it would embellish what the DEXA score is.
Perfect. And a question coming from Riva. I've been doing silver sneakers for 18 months, which includes balance exercises and
Qigong.
Yeah, thank you.
Right? I think I have it.
Yeah, my balance, has not improved. Since I have hearing loss, which I assume affects my balance, can my balance ever improve?
Yeah, so I'm from the school, I think everything can always improve if we dose our treatment properly. But hearing loss, as you've mentioned, Rivas, so nice to see your name. Hearing loss is a big part of balance, as well as visual inner ear problems otherwise, and then nerve damage. So I look at what each activity is within the pieces that you're doing. Balance activities, you should always feel a little wobbly. I'll say, I think that balance exercises are the most humbling exercises because you're always going to feel like you're not doing well with it. And that's the point. So if you can move through your different balance exercises and Qigong, and I think I'm saying it correctly, and you feel pretty stable all the time, then you'd want to advance those. So let's say, for example, you stand heel to toe and you feel pretty steady. Add to it some side-to-side head turns. You will quickly feel how you're falling off balance. And the work that your body has to do at that point is what ramps your balance up. Lower extremity strengthening is really important at the ankle, knee, and hip, especially the side of the hips. So doing some resistance training specific to those areas is going to be important as well. So hopefully within Silver Sneakers, some of the training is strength training, but again, it should feel challenging. So if I'm standing and just raising my leg out to the side and I can do that 20 or 30 times, I would want to add a resistance band or a weight to it or lay sideways to do it to make it harder. So fatigue during resistance exercises, off balance yet safe during your balance exercises, ramping things up. There's so many ways to advance balance exercises. That's going to be really important. So I'm hoping that gives you some wiggle room on how to advance things.
Very good. Thank you. Thanks. I never heard of that exercise anyway, so very good.
Really
Should we-
hard.
Yeah. Yeah. Okay. A question from Deborah. If you have a negative bone density test at one point and it's negative, should you get it again in 5 years to see if it's changed?
Yeah, and I think that's the interval that insurance is happy to cover this. So if a test is showing that you have normal bone density, 5-year increment would be helpful. The other thing is to look at those risk calculators for fracture, because what you're going to find is age does advance the risk pretty heavily. So I would do that as well as get your bone density tested. And if it continues to be in the normal ranges, another 5-year interval is going to be fine. If it changes, then that would tighten down and you'd have some different conversations.
Thank you. And a question from Jane. How does inflammation affect your bones?
Oh, I hope that Janice on next week has a better answer to this, because I'm not well versed in this, and I'm assuming it's part of the osteoblastic osteoclastic activity, but I have a feeling it is multifactorial and something that we know pieces of, but not all of those pieces yet. So that's not the best answer, but hopefully we'll be able to get more information next week.
Great. And one last question, Karen. What question should I ask my doctor if I'm concerned about my bone health as a person living with diabetes? And when should I start?
Yeah, I mean, I would start honestly in the 40s or certainly at the beginning of the menopause. And I think one thing that's important is to go in knowing that having diabetes does affect bone health, because every healthcare provider is not going to appreciate that. And it is so phenomenally important. So I would go in as soon as you've done one of the fracture risk calculators, or just go in and verbalize, I have diabetes, I'm concerned about my bone health. A DEXA would probably be ordered. And if it shows osteoporosis or low bone mass, then you move forward with that. If it shows normal, please still continue to question it. I know of people who have had fractures from low or no trauma, getting pulled over by a dog, being, falling down one step, falling onto the sidewalk, and they get their DEXA done and it's fine. But your bone quality should be questioned at that point. So DEXA, I'd really push for the conversation outside of the DEXA score if something like that happens. Really, really important.
Very good. Thank you. Well, we're just about to the top of the hour, so we are going to close out the questions. If you do have a question, you could actually send them as an email or send them to info@diabetessisters.org. And finally, a big thank you to Karen Kemmis, Dr. Kemmis. Thanks for your dedication and your partnership. And to all of you who have joined today, thank you so much for joining Diabetes Sisters in our webinars. We are thrilled that you're here and look forward to seeing you in our upcoming events. So have a wonderful day, everyone.